Okay, are you folks ready?
We're ready. Whoop, whoop, whoop.
We are ready. Okay. Hey folks, I'm Sevtap Savas and I'm very excited to have this podcast together with three other amazing people that I'm going to introduce in a short while. But first, I want to say that today we are going to talk about patient voice in cancer. We are going to talk particularly about what is patient voice, why is it important, how it looks like, what works in and what needs to be improved. I am with three fantastic colleagues today, Tracy, Judy, and Stephanie. Folks, thank you for joining us today. Would you like to briefly introduce yourself, starting with maybe Judy?
Okay. I'm Judy, and I live in PEI. And
Thank
what
you.
else? What else would you like to know?
Well, I think we will learn more about you along the podcast, so don't worry. Uh,
I will just say, in 2003, I was diagnosed with breast cancer, and in 2008, a new primary on the remaining side. And I've been involved since 2003 in a big way, in a number of advocacy ways, I'll call it.
mhm.
Okay.
Well, thank you, Judy. Stephanie, hi, how are you doing?
Hey, doing wonderful. Thanks for having me, Sevtap.
Yeah, do you want to briefly introduce yourself?
Absolutely. So my name is Steph Howlett. My pronouns are she, her, and hers. I am a advocate, certainly, of cancer care research. I've had the pleasure of getting to know these other three fantastic folks on here for the past couple of years. So I run a business called Diversity NL. I am a stage 4 ovarian cancer survivor, which is where certainly my advocacy comes from, and also social work background. So that's where it comes from as well.
Thank you. And Tracy.
Well, I'll start off by saying I think I'm a little out of my league today with you guys. My name is Tracy, and I'm in Newfoundland. And I was a caregiver to my spouse that had stage 4 colorectal cancer. Passed away in April of this year after a 6-year battle. And I became an advocate, I'd say, 3 years into his diagnosis, because for the first 3 years, I felt I didn't have a voice. I felt that cancer had taken my voice, but then I found it again and I said, we're going to try to make something, anything good come of this. So I started to advocate.
All right. So you folks nailed it. So let's start with talking about what is patient voice in cancer? What does it look like? Judy, maybe you can start, Stephanie, and then Tracy, we can have a round.
I always love to be last. Well, it means many things to different people. So I think that there is no one definition. That's my impression so far. And for me personally, what it means is that I don't just accept everything that I hear or see anymore without kind of questioning it. I've become kind of the old expression of doubting Thomas. And I've come to realize the importance of speaking out. And I would say what has evolved over time is the funders for research have made it almost an obligation, especially for pharma, to have the patient voice if they want to really be credible and be seriously considered for funding. And so what has evolved a bit, I know I'm probably saying more than I should now, is that they must have the voice. And so what has also evolved is there's an actual entity that has a panel on it of people that have been patient voice, and they have various opinions, and some of them are cautioning us to not be a piece of tokenism in those instances, because it can happen. And that's just the way of being efficient, I suppose, these businesses. And so I never want to be part of one like that. And so here I am. If I'm invited to be part of something, that's the first thing I ask is, what's your definition of patient voice? I'll leave it there for now. Thank you.
Wow. Yes, wow. Stephanie,
I
do you
think,
feel-
yeah, I think the thing is when you're talking about tokenism and research, I think sometimes they are obligated as part of their funding to have a patient voice, but it doesn't necessarily always mean that they listen or take into account what the patients are saying. They just are fulfilling another tick box on their funding grants.
Perfect.
Absolutely. Yeah, I mean, to me, that's the power differential that there is. If you're asked to sit on a committee or you're asked to sit on something, it's great. You feel that maybe there's a way that you're going to be involved in that. So you're asked to sit on it, but are you listened to? Back to both of your
Right.
points. So are you listened to? Do things come as change because of your voice in there, or is it skipped over just that you're that, like Judy said, token person? You're that figurehead for patients. Just to expand on patient voice for me, it's those of us who have lived experience. To me, is we're not treated as an afterthought. So we're more partners in that care, that research, the policy, the services, or the decisions that affect our lives. So it's the difference between saying we designed this for you as opposed to we designed this with you. So that's a big difference.
Wow.
Well said. I have a comment if I could.
Yeah.
Well said, both of you. You know this, I'm sure already, that UPEI has made a partnership with the Memorial to offer the medical program to would-be physicians, and they have a cohort already begun. And this bunch will graduate actually under the umbrella of MUN, but eventually in 3 years, it'll be through here. So I was very intrigued by an invitation to the public to fill out a survey or come in person to a 2-hour meeting with staff who are consultants in this kind of thing, looking for the public voice of what we felt should be included in that program for would-be physicians. And I thought, how exciting is that anybody gives a hoot what we think? Because the program already exists. It's a perfectly good curriculum. MUN has won awards for their curriculum. So it turns out that what UPEI are using is 20% of their own curriculum. And so that leaves them this opportunity to mold it with whatever is felt should be included in that program. So I did attend, and there were probably 20 of us. And I went with my colleague who's a co-facilitator of our breast cancer support group. And we were pretty impressed of the way they did it. And it was interesting, but I think it might have been a good learning experience for those that are compiling data to include in their new curriculum that they will devise. These are experts in curriculum design. I have a master's degree in curriculum design, but I certainly did not feel that I was speaking from that kind of perspective at this event. And we were broken up into table people. So the people at my table, we gelled well. It just all fell into place, and we gave our suggestions, and it was nice to see them on the board. So what becomes of that, I don't know. But isn't that a lovely example of awareness, at least?
Yeah. Wow. So you always surprise me, Judy, with your multiple qualifications, experience, and expertise. So today we learned your master's degree about curriculum development, which I'm really very bad at. So thank you very much for, I know that if I have any question, I'll come back to you. All right. So what else can we say about patient voice? Why is it important? So far we have learned that integrating and working together with people affected by a condition, for example, or people in the geographic area, like public engagement activity Judy just mentioned, to work together, hopefully solve and integrate as much as their as much as possible their recommendations, inputs, and so on.
If I could speak first before I forget what I need to say.
Yeah.
I have to say that, jump in here and say you are a good example of leading the way in that. And I don't say that out of blarney. I know a lot of Irish in me, but this is not blarney. You really are a role model, and that's why Stephanie and I did a little extra to make sure that Capo recognized that. And so it's kind of funny for you to be sharing, hosting this, because you are already an example of respect and all of the ways that a patient voice person should be treated, maybe over the top even.
Oh,
And so I just thought, I got to say it while I have a chance.
I'm eternally grateful, folks. I mean, I don't deserve these words because I try my best all the time, but I know that I have still a lot to learn. And I failed a number of patient partners myself, not intentionally, but the circumstances or resources did not allow. But, you know, there is always motivation. There is always this extra gratefulness that makes me learn better. As a matter of fact, I'm very happy to, you know, disclose this today. Like I say, you know, I don't know what it feels like to be a patient advisor or a collaborator or member on a table. I don't know this. So I said, I need to experience this. So I made a social media call saying, hey, if there are any patient-led, public-led organization on cancer who would like to have a scientist advisor or partner, please reach out to me. Like I would like to be on the other side of the table so that I will actually learn how it feels. How it feels. Like I really don't know because it's not in my lived experience, right? I'm hoping that such a opportunity will materialize and I will have a deeper understanding of you know, patient partners, people with lived experiences and so on, and their experiences. So, you know, this I can understand better and maybe I can improve better. So I think there are so many things that we can learn from you, but I really appreciate, you know, what you just told me and Stephanie and you did in the past. The same thing with Tracy. So thank you so much. But I'm going to be better. This is my promise to you.
I think up front you shared about ethics and confidentiality. This one I've shared with you before we started our podcast, that's a concern for me because it wasn't clear that I didn't meet criteria, and it should have been probably more clarified at the beginning. And it's not that I was holding back anything, but I don't fit the criteria that they need. And here I've been meeting with them since April. It's late in the day to find out. So as of yesterday. So I think that's an important aspect of any professional that's going to host something like that. And that, of course, that's how they'll learn. You know, these are PhD candidates in many cases. And so if you made errors and you're a professional big time, that's how we learn. It's
yeah. And I think, and this is how they will learn from you. Because if they knew, if they could have this experience, expertise, etc., they would probably approach it differently too. So I think when we work together, it's really essential that we are in the same space as researchers and patient partners or people with lived experiences in the same space. The same space where we know about the aims, goals, constraints, opportunities, what we are going to work on, and then provide or work on solutions within that space. Otherwise, if the space is not closed, if the space is not shared, I don't think we can understand each other that much. So learning is an important part of it, especially the patient voice, integrating patient and people with lived experiences in research, healthcare, policy, service, as Stephanie very nicely said, is very, very new. A lot of people are not the expert, but everybody's learning, so you can teach them. Right?
I think the other thing to mention there that's important is that there's not a lot of opportunities a lot of times for a patient voice in what's happening, especially when it comes to the healthcare system itself, when it comes to treatment options, when it comes to research it's almost like everything is already set in stone sometimes. And you feel like you have no voice. You're not a cog in the wheel. You're just watching the wheel go around. And sometimes you feel like that hamster. You're just chasing that carrot around the wheel, trying to get someone to listen. But it's just not always available. It's not always an option.
I think I heard this. I want to actually leave the stage to Stephanie. She has been waiting patiently, but I just want to briefly say that I have heard this before from other people interested in who have lived experience and interested in being a part of research policy service and so on activities in Canada. And they are calling up for a certain database where people would be, go and find those opportunities in healthcare, in research, etc. So it's a vision that can happen. It looks like, there is really a need. We have been hearing it from independent people, and with the resources and someone leading the work, it can happen anytime. So all you have to do is to go to that database, say, hey, select which province, which part, what opportunities are there, and then maybe
instead of waiting for it to pop up on LinkedIn or Facebook or something like that. Because if you're not following social media, which is what most of them are using a lot of times to recruit patient partners, like there's all these missed opportunities for patient partners.
For sure. Amazing. Hopefully it will happen. So Stephanie, how does so we talk about tokenistic, and I'm really interested in that because I was actually, I think, I was called tokenistic once or twice myself. I have no idea, but I'm really interested in learning about that, all right? And maybe also provide my own side. But this can wait. Maybe we can do another conversation about tokenism. But today, let's talk about, again, let's focus on patient voice. What works? So you all have been involved in advocacy and been involved in, research and public engagement and other activities. What works in patient voice? What are the good practices? Let's talk about those.
I think you need clear and concise communication first. From the very beginning, from the time it is posted or advertised or whatever their method is going to be, is that the communication must be clear and it must be in plain language. Not everyone can decipher the scientific jargon. And a lot of times they are excluding themselves because they don't feel that they have enough knowledge or that they can actually be heard in an arena with scientists because the actual posting is so hard to decipher.
Right. Perfect. Stephanie? Thank you.
Yeah, absolutely. I mean, I think a lot of people would want the uptake to tell their story and to have conversations with researchers in the medical system. They just don't know how to do it. Maybe they maybe not be tech savvy. Maybe they're not, like Tracy said, checking the spaces that maybe some of us are to see what's going on because let's face it, we've probably been in the system for a while. We've probably been involved in things. So we just kind of know more so than what maybe other people do. Not sure if that's good or bad, by the way, if we know all this stuff. However, I think we don't want to, we're not saying that we're the clinical experts. However, I think that when we work with clinical experts, that our system can become so much greater, working together. We see the holes in a system. We see the gaps in a system that maybe the system doesn't see because we're so integrated into it. We keep on going back. We have the appointments and we're seeing the pieces that might be missing. From my perspective, I've had great follow-up, great treatment, and an amazing physician here at the cancer clinic in St. John's, the Health Sciences Center. However, there's always room for improvement when it comes to any service. Sevtap whoever said that tokenism regarding you, I don't know why they said that, because I've never experienced that in the last 2 years of having opportunity to work with you and to see the awesome work that you're doing.
Yeah.
Maybe they have a different version of what tokenism is, but to
Yeah.
me, it's when you're not listened to, you're just put at the table and you have absolutely no say. But
Mhm.
I mean, for us, I think to have a say, not just a say, but to be honestly listened to, and for the person to come back that asked us our opinion to tell us what happened. What was that policy change? What was the research change? What was the follow up? What was that thing that happened and the outcome? Like, what was that positive outcome? Because we don't
What was
always
that
see the positive
result?
outcomes. Yeah, tell
Yeah.
us.
Yeah.
Perfect. Thank you again. Like, yeah, I think for you may be right. I think many people may have different understanding of tokenism, or they may not actually find opportunities to be in a way that they would like to be. So I recognize all of this. These are all possible things, right? So not intentionally, but unintentionally, I believe. In my practice, it's always unintentional. And if there is anything that I'm not doing, it's because of resources are not there. But I think we have to acknowledge that not everybody will have the satisfactory conditions that will allow them to feel like they are contributing. Because everybody contributes in a different way. From one day to other, it may even change. Today I may contribute, tomorrow I'm not. Maybe, So I understand that, I respect these differences, but I think tokenism within the research environment should be I think it should be discussed, and we have to see both sides' views. So that is one dialogue area that I'm really interested in, but maybe again another time. So, but I understand it's a very important part of it. People with lived experience, they want to be heard, they want to be part of solutions, and they want to be a part of the change. So let's talk about this change. So healthcare, right? I think everyone wants to change the healthcare for the better. How do we do that with the patient voice, folks?
I think it's important, like Stephanie said, that after you go and are part of the system and you're part of many years of the system, you are on the inside of the system. You see what policies work and what don't work. Because I think what sometimes is forgotten is that it is the patient that should come first. It is not the policy. It is not how things should be done. It is the patient should be seen as an individual. And I think the patient voice should be seen, each one as an individual, not necessarily all the time as a cohort, because patient voices may differ on a panel regarding something.
Yeah.
And I think it's important to recognize those differences.
Yeah. Absolutely. Diversity in opinions, inputs, and preferences. Certainly, this is going to happen.
Can I add to that?
Yeah.
So Tracy, yeah, to your comment that one voice doesn't mean it's the voice for every single person that had that lived experience
Right.
with whatever that was, whatever type of cancer that was, or whatever the family and entity went through. So it's not just having one voice, it's having a number of different diverse voices, to what Sevtap said, on that, whatever that committee is, or whatever that thing is that you're looking for, research or whatnot. So it's, because we all have that different lived experience, some positive, some negative, some, probably okay. So it's just building that into it. So it's not just one person that takes it on, like, I am that person that's speaking for whatever that thing is, because that doesn't make sense either.
No, I think it's important that the differences be noted as well as the similarities. In order for a positive outcome, you need to have a diverse range of experiences and opinions and backgrounds and whatever else. I think it's important in research that a lot of times they don't box themselves in to a certain patient voice that they want to hear. It's not always about that certain perspective. It should be about a broad range of perspectives.
Yeah, exactly. And that's why we have seen like traditionally, historically underserved communities, this, you
Mhm.
know, demographic groups, people, and so on. So you're absolutely right. You are nailing it. Now I want to go to Judy. Judy, because you have been very active in advocacy. You are involved in a number of organizations. You really are pushing for change. From your own experience, tell us a little bit more about, you know, how to actually uh, integrate patient voice in the healthcare policy changes, services, if you have any experience in this area.
They're so painful. I don't
I
know if
was
I'm ready to
expecting
go
that.
there. Before that, I would just like to mention something Tracy said about uh, would-be candidates to be a patient voice. I'll use our breast cancer support group for an example. Many of them are anti-technology and certainly not on Facebook, as myself. I'm not on there because I know I'd be on there all the time. I'm just too OCD to
Mhm, mhm.
pull away from it. So I don't
Yeah,
indulge because I know me.
yeah,
I'm not 16 anymore.
yeah.
So these women, so many of them would be interested, but everything is online now.
Mhm.
And so that voice is, you know, it's kind of
Yeah,
lost from the
yeah,
few
yeah.
that might want to step forward and share some information. Just something to mention to you because everybody just thinks everyone's wired up and they're not all wired up. The other thing is going back about 4 years ago, the Canadian Breast Cancer Network started being more of an advocate to get that information out there to those at least that are online on clinical studies that are desperate for patient voice,
Mm.
because they were finding it difficult to get them, and they're not permitted, of course, to give a list of people that are on their subscription list, right? Same
Mhm.
as Cancer Society. They can't, it's not ethical. So you have to try to woo them by way of whatever wording you use, that there's this wonderful project upcoming. Do you want to be part of it? I mean, they never put it like that, but that's I'm saying that. And so, being the way I am, I got too involved in putting my name forward for everything under the sun, which was way too much. And
Yeah.
so I'm learning to really be more discriminating. Um, the Saskatchewan Health Authority, in particular, have a wonderful webinar at least once a month, and it's always so far my experience in the last 3 years is it's very Indigenous led, and it's been a real learning curve for me because here in the island, many people think we're so underserved, but when I hear other voices from other provinces, we're not that badly off, no matter what people here are thinking. And what's my point? I'm sure I had one when I started this. Maybe I'll just leave it there because the political one is a biggie for me, and I know I will take up a lot of your time if I get into that because
No, that's fine.
I'm not too happy with that aspect here.
Yeah, no, that's fine. I think we have learned that you are very invested in this and really spending time and also observing. So your point about inclusion, right? We are not very inclusive. Even this is not very inclusive. We can't have a pod like everyone in a podcast unless we are in person or we go to them, right? So that's an excellent point.
A next example is CBCN had the best newsletter so many times a year, full of information in the old days before computer took over.
Mm.
And many subscribe to that.
All
That's
right.
changed now. There is no hard copy. And so if you're not online, you're really not getting that information. And the online is impeccable. I think we have the best site that shows clinical studies that you can access if you need it in Canada. That used to be very hard information to
Yeah,
access
yeah,
if you
yeah,
needed it. And
yeah,
now that's not the case. It's there. And we have an educator,
yeah.
Rebecca, who keeps it current and updated all the time.
Oh,
This is,
perfect.
I'm only talking breast cancer right now, of
Yeah, yeah,
course, but
yeah.
that's a wonderful asset we have.
Yeah,
How well known is that? I don't think it's well known. And
yeah,
so CBCN remains kind of under the wavelength, which
yeah,
is really sad to me. I
yeah.
thought when Canadian Breast Cancer Foundation folded, uh, I guess COVID, because they were all about research only, but people confused them with CBCN. And we've been here 32 years now, roughly, and I'm on the board. And so I thought, oh, we'll be better known. Now the CBCF is gone because they were always fundraising. And so they were well known. And they grew from a staff example in Halifax from about 2 or 3 people to 22. I mean, it was a real make work organization.
Yeah.
Doing good work as far as researchers go, looking for money for breast cancer.
Oh, breast cancer.
So I don't know what happens with the people that are not getting that information. That's why I mentioned that as an example. There's no more hardcover newsletters.
Yeah. No, I mean, I fully agree. So not everyone has access to internet or devices to connect to internet. Like I know in rural areas, this is particularly problematic, which is really strange, right? We are one of the G7 countries. We should have internet available everywhere. But hopefully this will improve over time. But I think, again, in terms of having diverse voices, inclusion, the issues are still there, but still, folks like you, Stephanie and Tracy are trying to improve things and bringing those to everybody's attention so that we can speak about them and maybe, we can advocate for them. So that's the best part of hearing these issues so that we can, put them on the table. So thanks for that. All right. So, So Judy, I was just asking about, what really works in patient voice. What practices do you see as good? Like we talk about, print copies, working with, that's great. And Tracy talk about, open communications. Nobody needs deciphering something, which is perfectly fine, and providing, enough information about what the aim of this partnership or work is. But excuse me. But what else do you folks think that is really making the patient voices heard out there, been there? Or what needs to be improved? What doesn't work? We talk about tokenism. Obviously, it doesn't work out, right?
I have to leave for 1 minute.
Okay.
So I guess a couple things. So one under opportunities, and other one's under barriers. So opportunities, when it gets into, we talked a little bit about, the feedback loop, closing that. So, tell the person what was heard, what changed, and what still needs to work. I mean, that's a big piece that we don't hear enough. So when we're involved in things, we don't hear the outcomes. We don't hear how the work that we've done, how it helped change something, or what was the end result. That's a big one for me as well. I wonder if we shouldn't be, training leaders. So, health leaders, so they need to hear the difficult things, because it's not always positive feedback they're given, so they need to hear things without being defensive, and to turn lived experience into that improvement within the system. And that's a difficult one for people to hear something negative about potentially their leadership style or what they're doing, and turn that lived experience they've been told into an improvement, because sometimes then we get offensive about things. So, and I get that. So those are a couple of things for me as well. I mean, there's lots of different things. I mean, compensation as respect. Lots of times people get asked to do things without compensation. To me, it's helpful if someone offers something. It's always great as well, but none of us do that for that reason. Creating safer spaces for us to have conversations. Tracy mentioned it earlier about basically using plain language. Some of us might know some of the language, some of us may not. We may not understand our clear roles. Like, what is our role as that patient voice? Are we psychologically safe to have the conversations that we need to have? Is the group we're working with, are they open to hearing maybe some of the trauma or some of the things I've gone through? So I need to express that in order to give you an example of how things may change. And I don't, that's not always there. So how do we, create some of these things?
Wow.
Yeah, like how do we make it okay to sometimes not be defensive about what's being said? Because patient partners don't always have a positive experience to contribute.
Yeah.
They don't always have the yes voice.
Yes. Yes.
They may have a very strong opinion about something because of lived experience, because of trauma. And I think it's important to recognize that not everything is going to be positive.
Mm, mm, mm. Fully agree. So I remember like when I first started public partnership a while ago, you know, we look at the people, we look at the needs of the or priorities of the people affected by cancer, whether they were caregivers, family members, or survivors themselves in Newfoundland and Labrador. So of course, you know, some of these things is related to healthcare, right? And then, you know, healthcare providers somehow, at least one or two of them get a little bit defensive by this work because they say, you know, we are trying very, very hard to provide the service, which I kind of understand their predicament as well. Like it's a difficult situation, right? They are working very hard. We know they are understaffed and so on, and they work within the, you know, very strict rules. I found the medical care very strict, you know, very on the paper kind of following the rules kind of profession, and maybe with some sacrifices as well. I don't know. I can't really speak for them. And then when they hear that, you know, the healthcare service that they are providing is not always appreciated, I think this is where they get defensive. So I understood that one, right? But I guess that's exactly why we really need to be on the same space, in the same space, to understand the patient side and the healthcare system side, or healthcare provider or researcher side. So because everybody has certain constraints, right? The healthcare system will not be able to change everything we advocate for. If they had changed, it would have been changed. They are not going to change. I'm surprised myself with all the advocacy work, research we do is still not changing much. But I have seen, for example, there are good examples. For example, you know, via the Advocacy of Canadian Cancer Society, the screening age for breast cancer has reduced a couple of years back, right?
Mhm.
Through the government. So I come to understand that the healthcare system can only change by either evidence, because they are very evidence-based. The treatment, services, everything is evidence-based, cost-effective, where the benefits outweighs the, you know, the cost, or it comes from the government. So there are three ways as an advocate that I understood in my last maybe 6-7 years of very intense advocacy, that these are the three things that the healthcare system and policies may ever change: through government, through medical evidence, and through cost effectiveness, because it may be useful for one group of patients, but if it's not useful for, you know, over the, I don't think they are going to do that unless there's a push and unless there is a good reason. So I'm a little bit not very optimistic in this area, but I also understand the importance of advocacy, especially through government. And the other thing is, of course, creating evidence, right, to change things. And this is where the patient and researcher collaborations work together are actually the most, I think, critical ones, because this way we can actually integrate the, you know, patient voices in the research, hopefully create the evidence that the healthcare system may work on, and then someone can work on the health economics and policy, and hopefully it can be integrated. It's a long way, folks, but it will happen, and it's an integral part of it. Without advocacy, a lot of things may not change. So I'm hoping that, you know, with this growing body of advocates and people with lived experiences, things are going to be so much better in such a shorter time. My 2 cents.
I'm
It's a
not
great
quite
2
as
cents.
positive. I'm not quite as positive. I'm sorry, but the amount of resistance to change sometimes is overwhelming. And as an advocate, I think sometimes it leads to feeling that you're not changing anything, that
Yeah.
no one is hearing you
Yeah.
because you
Yeah.
keep encountering the same barriers,
Yeah.
maybe at every visit.
Yeah.
Maybe you keep hearing
Yeah.
or experiencing the
Yeah.
same barriers, and you speak and you ask and you advocate,
Yeah.
and you go back a year later or 2 years later or 5 years later, and things are still the same.
Yeah.
So I think advocates sometimes get burnt out.
Yeah. What a heartbreak is it, right? So I
Right.
remember just recently, I think last month, I was like, is anything I am doing or we are doing changing anything? Like, is there in the world
Right.
any of these, right? And it actually made me feel like, okay, maybe I should stop doing this,
Right. I think it's
right?
very hard to keep going.
It's very hard to keep going.
Right. When you don't see any change,
Yeah, yeah,
or when you don't feel you are being heard.
right. But I think, and then I say, you know what? Then I look at the examples of advocacy, like HIV movement in the past. I think they are a great example of how people's advocacy changed a lot of things in healthcare. So when I look at those successful examples, I say there is hope. So that's why I'm hopeful. It happened in the past when things were much harder, and it can happen here as now as well. We have to keep the hope.
Tracy is right, though.
Yeah.
And it's hard to not be discouraged
Yeah.
with the politicians. I can give a good example, if I may. Are we short on time here, or what?
We have time.
Dare I bring it up? Okay, so starting about 8 years ago, or maybe a little more, our former premier, nice person, but naive, kept telling us that we had to go to health PEI if we want to make change. Another layer of bureaucracy we have here. And so we met with wonderful staff from our hospital who listened to our concerns and assured us that we had the power because we're the people, but it's not with them. It had to be with the Department of Health, and its long name. And so we go back to the premier, literally. And there's something up there now. You go back to health PEI, blah, 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 blah. So here we are 8 years later, another premier, have to start all over. And meanwhile, the protocol, we just can't make inroads to get it changed to be inclusive. And it's policy, and it's in black and white. And to put it to the test, my GP agreed to send a requisition to the screening program for me to get an ultrasound, because that's how I was diagnosed both times. Because those with high dense tissue are at risk of it not showing up in a mammograph, cancer. And so I'm one of the lucky ones, because I came from Nova Scotia. I only moved here in 2000. And there, the policy was, if you have high dense tissue, you got an ultrasound as part of the screening program. So when I came here, I expected that. And I was fortunate, at least the 2 times that I've had breast cancer, that's how it was diagnosed early. And it's likely why I'm still here. And so that's knowledge that we know now in a more bigger way, that those with high dense tissue have the right to be screened, but it's not happening. And so it's worse now. People have to go pay for it and go off island to go get it if they want it. And do it here. We have 3 in our support group, diagnosed at ages of 32, 40, and 60, all high dense tissue. Knew that. They should not be getting diagnosed at advanced stage. Because of neglect, really. It's medical neglect. So how we get this? What we were after was such a simple thing, to get the brochure on this information changed. Instead of saying follow-up may be necessary, explain what that is. Explain that you, as the person, have to be your own advocate and ensure that follow-up happens. But anyway, my GP did send mine in, and a nice rejection letter
Oh.
from the radiologist saying, here's the screening protocol, and ultrasound is not part of that.
Yeah.
So she said, okay, I'll order an MRI. She said, it may take a year for you to get it, but we'll do it, see if it ever happens. Because now GPs can order MRIs. They always used to have to go through what do you call them, Stephanie?
Well, the radiologist here
has
to approve.
Specialist.
A specialist anyway.
Yeah.
But now a GP can. So she just did that to see if I'll ever get that follow-up. But anyway,
You got it.
that's an awfully simple request to improve a brochure, so that at least if like the young woman that was 32 diagnosed at stage 4 knew that she had high dense tissue, but she didn't know she had to activate to try to get the follow-up with an
Judy, like, what does that mean? Like this young person's thinking, well, my doctor will, like, so a lot of people sit back and we just feel like our doctors will, okay, they'll do that because maybe, it's needed. So, but I'll just wait. Like that's a lot of people just sit back and wait.
They just
and
get
it's
a
just
nice
like,
normal
yeah,
mammogram. So that's another reason she couldn't finish the conversation. She was too tearful, busy blaming herself for not knowing more and being her own advocate. She didn't know better. There was no conversation. It's not in the brochure. It's just so sad because it is the younger women that it seems to be hitting. Anyway, not just here, across Canada. So I'm not too happy with our politicians who supposedly listen and give you time and waste your time, and nothing happens. So this is going on 8 years that our group is. We wrote letters, of course, and sometimes they're answered, but it's just a token. It's tokenism.
Okay. Yeah.
To Judy's point, if you don't know, you can't do something to help yourself. So there's a lot of people who are uneducated and just don't know. So a lot of people think that our physicians know all of it and they will take care of it. And that's a great thought process, but that's not the way the system works. That's not the way we work, right? So our GPs are so overtaxed. Have a fantastic GP, but she's not going to get everything, right? She's not going to get it all. We need to be firsthand asking the questions, asking for things that we need, and insisting on sometimes, or if not, like we're going other places to have conversations. So, but a lot of people don't do that. They don't feel that they have the voice, and they certainly don't have the knowledge. And I think that's a huge holdback.
It's true, and many don't have a doctor, and so here we're fortunate to have navigators for almost everything you can think of, from senior interest to housing to cancer navigator. But this person doesn't know they have cancer yet, so they're not going there for information.
It's big, concerning.
So, and I think, Judy, we had this conversation, and thanks for your advocacy about the dense breast and the way to actually screen for breast cancer. Like here in Newfoundland and Labrador, I'm eligible for, my age allows me to get mammography every 2 years. We get the density percentage, but nothing else. How am I supposed to know what this percentage means? I don't even know whether it's a high density, it's a low density, what I'm supposed to do with that information.
So thankfully we have Dense Breast Canada, who's trying to get that information out there, if you're listening, but you may not hit that information. So if it's C or D category, 50 or 75%, you need follow-up. You absolutely must have follow-up if you want to catch it early, because having that dense tissue, unfortunately, makes one more at risk of developing breast cancer in the first place. That's number one. Number two is the idea that you need the follow-up.
So, I mean, this is something that I really need to work on, because they gave me information about the percentage, but nothing else. So I really don't know whether I have dense breast and I need to advocate in the clinic or not. But this is something certainly that I need to look into.
Well, what I discovered is that information doesn't cost radiography any extra work. It's in the report. It's just doctors didn't necessarily ever mention it to the client. And I think it's just lack of knowledge. They probably didn't know that meant you're at high risk if you have C or D or 50 or 75%. So at least what we're getting out there in a better way is they are having that conversation. But it's not going to go anywhere because the protocol stands firm. No follow-up as part of a screening program. So what we have are women going off island that know to do that and pay for it and get it elsewhere. An ultrasound will usually be enough. You don't necessarily need an MRI. And how long does an ultrasound take? 2 or 3 minutes.
Yeah, yeah. No, I mean, it's to me, it's very strange. They give me the percentage of density, but nothing about it. Nothing about it to empower me or my GP to follow up. So
Well, it's a wonderful teaching opportunity if you can get
yes,
that person
after
and
that.
give them the Dense Breast Canada website so they'll go and learn something.
Yeah.
But you will know more and you
Yeah.
can teach them.
Yeah, because I think I'm more like, what Stephanie described. Like I trust my medical team to give me the best care possible, and I don't want to go to the Dr. Google, search everything and get crazy. I
Oh,
did
I'm
that
not
in the
suggesting
past.
you go to Google. I'm suggesting
yes,
you go to
yes.
Dense Breast Canada and you'll
Yes,
be
yes.
informed fully.
Yes, absolutely. No, your point is was much needed and taken. So thank you for that. Yeah, I should definitely. But I know a lot of people who goes to Google and search things, if not even heard, hearing about Dance Press Canada or other. So we have a lot of issues like misinformation, the disinformation, to various highlight information. We can't solve all of this today. But what I'm seeing today is that the future is really bright. We understand from the beginning, like its importance of patient involvement in everything from service, research, healthcare, policy change, and everything related to health, in cancer or other conditions, because people have blind spots. We may not know. I'm as a researcher, I don't know everything. People with lived experience of cancer may have. I had blind spots. I still have. For example, in terms of power differential, I don't feel it, but I acknowledge that it exists. I just don't know what it means in my reality. But there are things that I need to learn, right? So that was a blind spot, and there are a whole bunch of other blind spots. So the communication, clear communication, the role clarifications, use of simple uh, language, and having a safe space, and what else? Compensation came out, offering it as a compensation because everybody, I think, may have different preferences for how compensation may look like or recognition may look like, from acknowledgement taking notes to, monetary, certainly honorarium and covering other expenses. And it's a psychologically safe environment. Sometimes it may be very difficult in when you are dealing with multiple people in such a vulnerable topic, such as cancer, for example. So that's an excellent point to make. How do we ensure psychologically safe? And also when you are heard and involved in a work, what at the end, what happened? Just let us know what happened at the end. Is it a report? Is it a paper? Is it a conference? Is it a policy? Is a I don't know. What is the output? How did your involvement, patients' involvement, public involvement actually change anything? So I think this is the primary motivation, right? We want to change things for the better. So folks, that's why having advocates, people with lived experiences, having them in our every activity and listening to them and learning from them is important. Any final words, folks? Did I miss anything important? Any final words about
I can go.
patient
I can go
voice?
first there.
Yes.
Yeah. So I think if we want a safer, more equitable, more compassionate healthcare system, patient voices cannot be left out. We can't be an add-on. We have to be, involved from the beginning when there is a policy being made, when there is a change being made. It has to be built into research, services, safety, leadership from the very beginning. We're a part of this. My lived experience is not someone else's lived experience. So what I've gone through is not what Judy's gone through or that what anyone else has gone through. It's just that it's my lived experience. But I would like for us to be able to have conversations with those in authority and power that maybe this is a different conversation for them. Maybe they didn't know this gap, or they didn't know this, as you put it, blind spot, because we all have them. Sometimes when we're working in a field for a long period of time, we feel that we know all the things, which we don't, because we've probably never been on the other end of experiencing and feeling. So I just want to put out there that we just want to be a part of that equation. We don't have the clinical expertise, but we do have the other side to be able to help.
Wonderful message. Thank you. Judy, any final words?
That was so well said. I can just echo onto that. That's perfect.
Yeah, absolutely.
And thank you for this opportunity. I don't know who sees podcasts, like where it goes, somewhere out there in cyberspace, but I think it's such a worthwhile effort, and if it makes somebody more aware, good for you for initiating. Lymphedema is preventable. Still, some doctors do not believe that, and so years ago we had a wonderful volunteer program that Cancer Society dropped, even though it didn't cost them money, because we were all volunteers. We made a visit to that person newly diagnosed, and they learned how they might help prevent winding up with lymphedema, which is a limb so swollen that it's painful, right? And there's therapy for it, but there's no cure. So you want to prevent it. And we did a good job, but it's gone. That whole program is gone. Heartbreaking. And anyway, it's not all stuff that costs money. It's just information sharing, and not saying we know it all. It's nothing like that. It's just the gentle voice of someone who has walked the journey, which is often, sometimes that's what people want. They want to talk to somebody who's been there. I don't like the term survivor anymore. I don't even want to be called a warrior. And that's why patient voices become more comfortable for me. And it doesn't, as Stephanie said so well, it doesn't mean we know it all, but we know a portion that can be helpful. Anyway, enough said. Thank you so much.
Enough said. Thank you. Thank you, folks. Tracy needed to leave us earlier for, I think, work-related things, but thank you. We had a wonderful conversation. I would like to continue, if this is okay with you, with further stuff, like let's talk about tokenism, let's talk about, more details, and how we can effectively advocate maybe for the healthcare. How do we reach out to others? How do we build up our base advocates coming from the people? And I want to say also that my future vision is this. My future vision is that the healthcare system is actually led and designed by the patients.
Wow. I vote for Sevtap.
That 20% curriculum that PEI hope to develop themselves will have an influence from people like you and your medical program there.
Absolutely, because in addition to lived experience, you folks have a whole bunch of other stuff. Like we learned that, Judy had a master's in curriculum development. We know Stephanie has a lot of diversity-related work and social work and so on. So why not? I think it's worth having such a vision and see how that will work out. And I want to just say that this is my dream. Because when I think people with lived experiences who are really much affected by the conditions themselves create that space, lead that space, I think things will be much better. And I think they also will understand better, the importance of resources and how to be effective and how we can do this effective together with other professionals, in the field. So this kind of collaboration is what I think this kind of workspace and collaboration, I think, is what we are looking at in the near future, hopefully, and which I hope that will solve a lot of trouble for us. So thanks again. With this, I'm going to close up. Goodbye.
Thanks, Sevtap.
Thank you, Judy. Bye.